Okay, hello to everyone who will be viewing this. It's been a little while since Josh and I have met to discuss the state of the pandemic. We felt like it would be important to have another conversation about coronavirus, kind of the current state of Omicron and these new drugs that are being developed and the vaccines and just the state of the scientific and clinical aspects of SARS-CoV-2 at the moment. Today is January 6th of 2022. I had to look at the calendar. So, hi Josh, how are things going over at Gable these days?
Well, Adam, sadly, it's busier than ever. We had high hopes for 2022, and then Omicron decided to crash the New Year's party, I guess.
Yeah, it's crazy, right? Just when you think, yeah, the numbers are coming down and things are looking up, new variant and changes the conversation, and it almost sounds like a transformer. That's what I've been kind of saying. It sounds like right, Omicron sounds like one of the Decepticons or something.
It would definitely not be an Autobot.
It would not.
Definitely not be an Autobot.
Would you want to kind of start things off with maybe look at the numbers, and we'll use that as a jumping off point?
Sure. And the numbers just have become so staggering. I can talk more about that in a second, but as of today's date, we're approaching the 300 million mark for total cases worldwide. And unfortunately, almost 5.5 million deaths. In the United States, we're at 57 million cases and over 800,000 deaths.
And if you want, you can share your screen as well. It's up to you, though.
Yeah, I already passed it, Adam.
Okay, that's fine.
Let's move on. Now, these numbers, though, we just talked about it before we got started. Over 1 million cases reported for the first time in the United States. And then the next day, the cases came down. So whether there was a little bit of a backlog and the million was a little bit of an exaggerated number, it was 800,000 the next day. That, for some reason, that 800,000 mark really struck me, because I remember saying we're almost at 800,000, or almost at 800,000 cases in the United States, and we couldn't believe there were so many cases in the United States as a total number.
Total number, right? Not daily.
We have that number as a one time.
Yeah.
I still vividly remember when Italy had 1,000 cases, and we thought, oh my gosh, there's 1,000 cases in Italy. And, kind of flash back to the people singing from the balconies and those moments. But now that's just a tiny little drop in the bucket compared to what we're dealing with right now.
Yeah, the virus, I think, is evolving, and I think it's pretty clear at this point. If there was any doubt before, in my own mind, I don't think there's any doubt any longer that this is definitely going to be, become an endemic, virus, meaning it's going to be with humans. It'll probably become the fifth seasonal coronavirus that becomes endemic in the human population, and hopefully it will evolve to become a little bit less virulent. It's still dangerous, and there's also issues with long COVID, which I feel like it's not talked enough about. It's affecting my own family, for example. I mean, my wife, still a year out, she had what's considered a mild illness, just a little bit of GI symptoms, like a day of fever, a couple of days of a mild flu-like illness, right? Never short of breath, never, a concern, luckily. And still to this day, doesn't have her full sense of smell back, has, I guess, what you might call brain fog, giving out phone numbers, or just sort of general, she sort of describes it as general processing speed of just sort of like sometimes thinking through something. She just feels like something is pulling her back, so it's and if that's the worst of it for her long COVID, it could be, of course, a lot worse. There's a lot of reports of even young, healthy people who, can't go jogging anymore, or who can't smell, or, have joint and pain issues, autoimmune disorders that have popped up. I mean, this is not just the regular flu. And I wish that people would stop talking about it like that. So what's, in your mind as a physician, what's kind of the, the clinical state of things at the moment, especially with the new variant?
As you know, Adam, I see lots of cases of COVID, lots of suspected COVID. And so, so I do get that personal, kind of in your face observations, and I've had tons of these conversations with people. And it's tough to sort out, just because even though I see a lot of cases, and we've had over 200 cases here on campus over the pandemic. We've had quite a few cases just recently that are most likely the Omicron variant. But it's hard to piece out with that even with that number, you still have a lot of people that are breakthrough cases, vaccinated, unvaccinated. We've had cases, we've had positive antigen tests that appear to have been false positives. Even though it's very rare, when you do thousands of tests, you're going to have a few that appear to be false positives. We've certainly had our share of false negative tests too. And when you have a symptomatic patient, you really have to piece together, how many times you're going to test them, what kind of tests you're going to use, how suspicious are you that this is COVID. And then you have people that have other issues going on that it's really hard to sort out sometimes. People with chronic sinus problems, people with chronic allergy problems, people with chronic asthma problems. Are these things from their underlying disease? How is COVID related to it? Which is from COVID, which is from their chronic problems. So it's really difficult to sort out some of these things. And and sometimes you try a treatment to try to attack what you think is the underlying issue, whether it's allergies or whether it's possible sinus infection or ear infection or one of those things. And then you look at the response and you say, okay, good. That patient got better with amoxicillin. That amoxicillin doesn't help COVID. Neither does Zithromax, by the way, but let's not get into that. But when the patient improves, do you say, well, that's because of the medicine I gave them, or that's because this was COVID and they're doing better now? So you hear a lot of anecdotal reports, and you can never put a whole lot of weight into that, because even though I like to feel like I'm helping patients by giving them things, a lot of times patients just get better on their own. And so I think overall, if COVID isn't a humbling experience for physicians and scientists alike, then you're kind of missing the boat, and you really don't understand what we're dealing with right now.
Right, that's a good point. We've heard a lot recently, some people are saying, oh, it's not as big of a deal. I mean, some pundits and some people, oh, it doesn't look like Omicron's as big of a deal. It appears more mild, less virulent. I have my own thoughts on that, but I wanted to get your take first as a physician, whether or not you think that's true.
No, I definitely don't think it's true. And I definitely was irritated just this morning. There was an article about pediatric cases, mostly hospitals in the South. And they reported a 1.5% mortality rate for hospitalized kids, the 5 to 11 age group, because of the discussion now and with boosters, vaccine boosters in kids, and 1.5% of the hospitalized kids with COVID died. And one of the comments by the person who wrote the comment had doctor in front of their name. I don't know what kind of doctor this person was, but went on to say that this is nothing. This is a mild illness. And I think to myself, if you admitted a patient, a pediatric patient, and you knew there was a 1.5% mortality rate, you would be really worried, because kids generally get better. They get sick, they get better. Even when they end up in the hospital, they get better. And so there's very few things that carry greater than 1% mortality rate that come into the hospital. So to see that and say, oh, it's only 1.5%, this isn't geriatrics we're talking about. These are kids that come in and should get better. Obviously, kids that are succumbing to COVID are much more likely to have multiple medical problems and much more likely to be considered medically fragile. So it's not something that that we should panic about. And if your child ends up in the hospital, yes, they're still very, very likely to get better very quickly. But it doesn't mean it happens for everybody, and it's definitely something that we should continue to try to take care of.
Right. Yeah, and I don't think we know enough at this point. I mean, Omicron is still relatively new. I think it's way premature to make claims that it's a more mild illness. There's so much, because of vaccination and also just natural immunity that people get from just having had a previous variant. There's a fair amount of pre-existing immunity out there. And so
that's a great point, Adam. A lot of where that information is coming from is that in South Africa, the hospital rates were low. Well, in the United States, the average age is around 37. In South Africa, it's 27.
Right.
And they've had, like you just said, they have a lot of natural immunity there. So it is definitely a potential apples to oranges argument. And
I think it might be, yeah. I mean, if I was unvaccinated, right, which I'm not, but if I was an unvaccinated person who has never had coronavirus, I don't think there's enough to say right now that in those people it's more mild versus, say, Beta or Delta or any other variant. I just don't think that people can say that. I think it's way premature, and I think it's very misleading. It could make people think, oh, it's not a big deal, let's just go get it, right? If you haven't got it already, right? Meaning the infection. I think it's very dangerous, and I have very strong feelings about that.
I agree, Adam, and that, I think that is bearing out already, because you have people that because Omicron is evading our immunity, we have more breakthrough cases. So our vaccine effectiveness isn't as great as it was. So we have this large number of cases, but people that are vaccinated, some of them are vaccinated, so it's still protecting them against severe disease, but it makes it skews the numbers. It skews the numbers. And if you look at you look at the people that are in the hospital or dying from COVID, they're unvaccinated. So
yeah, by and large, they are, yes. And even today with Omicron, with Delta, with Beta, whatever variant you're looking at, the data say that 95 or more out of 100 people that die in an ICU right now are all unvaccinated people. And some of them, frankly, are people who have been previously infected also. I don't want to oversell the vaccine. I'll just say that there's no downside to getting it. And even if you've had the virus, getting the vaccine just will further enhance your immunity. It makes it all that much better. And I mean, there are reports all over the place of people who have had the virus before who are still ending up in the hospital. That still happens sometimes with the vaccine. I'm not going to say it's like a panacea. However, I think the vaccine is holding up very well. And I would argue that it's equivalent to prior immunity and probably better. I would say the data suggests probably better overall. We had talked about this before, Josh, but the one issue I have with sort of natural immunity and relying on that so much is it's very inconsistent from person to person. It could be undetectable. Some people, you go take an antibody test or do a T-cell assay, and they're undetectable levels of immunity, whereas some people have very high. So I think natural immunity has a role, and it can provide protection, but I would not rely on it solely as my sole source of protection. I wouldn't. I mean, like I said, there are people that have had the virus before who chose not to get vaccinated who are still getting infected. Some of those people are still getting severe disease. It's not, so a natural infection is not a panacea. Vaccination is not a panacea, but it's the best we've got, and it's really good. The vaccine is really good. Did you want to say anything more on that kind of note?
Well, I think the one piece to add to that is that because early on it looked like natural infection was pretty good and it was holding up, but then you had people getting second infections, and now if you're a year out from your infection, you probably are not in that good a shape. And now with Omicron, even if you've had two infections, it's people are getting that third infection. And like you said, you read a report of even 4 infections. So now is the time. If you thought, okay, I had natural immunity, I don't need to worry about this. You better think twice and just go get it. On top of that, now it's a year out, and there's billions and billions and billions of doses out there. So unfortunately, there's been a lot of fear mongering with vaccination, like there's always been. But you have to ask yourself, if there was horrible things happening from the vaccine out of billions of people, I think it would have turned up more than 1 or 2 or 10 or 12 people on TikTok or on other social media outlets saying that things happen. Now, we do have to be aware that people have reactions to vaccines, and they are mild and often similar to what people get with the disease, but less dangerous, and less than what you would get with the wild type infection.
Right. For example, like there's been a lot of press about J&J causing, the Janssen J&J vaccine causing myocarditis and risk of clotting. The risk of myocarditis and clotting is way higher from actual coronavirus infection than it is from the vaccine. And we're talking about several cases out of hundreds of thousands of doses. And so again, it's, you weigh your risk, probably go get Moderna or Pfizer. I know that's what the CDC and FDA are recommending. They're preferring Pfizer and Moderna for that reason, but J&J is still a safe vaccine historically. Compared to all of the vaccines we have, it's still really safe.
And Adam and I, we've talked about this before too, but and now we have to reassess with the new variants. Everything has to be reassessed as to what the best option is. It is. I thought that timing on the CDC announcing that was very poor, to be honest. As a new variant is coming forward to make a preference on 2 vaccines over another, at least in the United States. I didn't think that was very helpful. Just go out and get a vaccine. If you feel comfortable with one, go get it. The CDC, yes, put a preference on it. And so, follow the CDC. That's fine. But just go get one wherever you can.
Yeah, it like I said, and it does decrease your risk of long COVID, having these long-term symptoms. It drastically decreases the risk of severe disease, ending up in the hospital. It really is the right thing to do, I think, both from a public health standpoint and from an individualistic standpoint. I also just wanted to touch on briefly, I hate the word breakthrough infection. I really do, because these vaccines from day one, their job and the metric that they were measured against was, does it prevent, severe disease? Okay. And they're still doing that, even with Omicron, right? They are still seem to be, and I know it's premature, and I don't want to also fall into a trap of saying, oh, well, it's premature for that claim. It might also be premature for my claim, but it does seem, as more and more people are getting infected, and it's spreading thousands of people every day, it does, I've been listening to infectious disease doctors, with some podcasts, reading articles, like news reports. It does seem that very, very likely that the vaccines are going to hold up even with the new variant. The actual percentage, right, might drop a little bit, but I think that they're still going to be in the 80s or even 90% effective at preventing hospitalization due to Omicron. I really believe that. And so, yes, there's more breakthroughs, okay? There's more incidents of people getting a positive PCR or antigen test if they've been vaccinated and then exposed. That is absolutely true with the variant, because the variant, it evolved likely to evade our immune response. So it's doing that, and it's doing that pretty well. But the metric we should be most focused on is not case numbers per se, but hospitalization numbers and deaths. And I still think that the vaccinated are going to be protected even from the new variant. That's how I'm reading the tea leaves, so to speak, at this point. I'd be happy to entertain other data, but that's what I'm seeing. Are you seeing something similar, Josh? When you look at things, something different? What do you think?
No, definitely the same. And I'm with you, Adam. I even from the beginning, I hated the term breakthrough, because that's the way vaccines work. Like you said, natural infection, your immunity is all over the board. With the vaccine, it's much more predictable. And that predictability includes the fact that some people don't respond quite as well. And some people don't respond at all. And those are very small percentages, but those are the percentages. So that's, if you use the example of a 95% effectiveness vaccine, well, then 5% of people aren't going to have that benefit. And that benefit might be hospitalization or death or whatever the measure is, or it might even just be infection. So, we have these categories and we say, well, the vaccine works this well, but like any medicine, it doesn't work for everybody all the time. And so you have people that, that think that they're protected and they may not be. But that's the nature of vaccinations. So yeah, I don't like breakthrough. I don't like the term breakthrough at all. It's what we've kind of been stuck with.
Right, because that's, I mean, especially for a respiratory pathogen like this, they're notoriously hard to prevent and prevent infection altogether, right? The virus or the bacterium, let's say, whatever you're talking about, enters the body and it is literally stopped in its tracks, like just halted, 100% halted, right? In the field, I mean, we call it sterilizing immunity. For a respiratory pathogen, it's really, really hard to have sterilizing immunity using any kind of therapeutic. And so for a vaccine to a respiratory pathogen, the goal is to prevent disease. And I still think it's doing that very well, even in the face of Omicron.
Yeah, to me, it makes a lot of sense, Adam. And you deal with this much more, but it gets into your nasal passage, and invades those cells, and then kicks off from there. But your immune system isn't, you have immune cells in that area,
Yeah.
but that's not what's going to clear it out right away. Those are the points of our body that are saying, hey, there's something going on here. We got to get going to get ready to fight this thing off. They're not right there. The soldiers aren't right there ready to attack and knock this virus out at that point. Because you can't do that. That's what rhinitis is when people are allergic and they have that issue constantly because their body is on guard constantly, thinking it's constantly being attacked, and that's a problem. You don't want to be in that state. You want to be in a state where your body is reacting appropriately, and so in order to have that appropriate response, it has to get in there and replicate a little bit, and your immune system has to build up at the next level of defense, like you said.
And what they've shown as we've gone through the pandemic is that the virus likely causes disease because it gets to the lower lung. You get your pneumonia, and then it can spread and cause the inflammatory syndrome, et cetera, right? So the vaccines and people that have effective prior immunity from getting infected, right? Their immune system is keeping it from getting to the lower lung, basically. If you keep it up here, then it's just sort of a cough, maybe runny nose, fever, right? But that's the worst of it. It gets severe when the virus travels further down into the lung. And so your immune system with the vaccine or some kind of prior immunity that's actually effective, it's preventing the virus from getting into that lower airway. Yeah, so in the remaining time, I thought we would just sort of run through some recent developments on the therapeutic side. I first wanted to start with the monoclonals. Earlier on in the pandemic, it really was kind of a game changer for a lot of people. If you could get them, they're a little expensive, a little hard to get, but what's been shown with Omicron recently is that, you know, the issues with these monoclonals is the word mono, of course, means one. And we talk about this when I teach immunology. You know, it's a cocktail of maybe 2, 3 antibodies, but each of those binds to just a very specific site on the viral protein, on the spike viral protein on the outside of it. And so some of these monoclonals are being shown right now not to hold up against Omicron, because that one specific binding site is now mutated, and so the antibody has nothing to bind to. Some of the monoclonal cocktails are holding up, some are not, and that was not the case for Delta strain. That was not the case for the Beta variant. But for Omicron, it's definitely evading some of those monoclonals, and so some of those are likely not to be as effective. Like I think, for example, one that comes to mind is the Regeneron one. I think I was reading about likely binds to some sites on the virus that have been mutated pretty heavily in the Omicron variant. But the advantage to, you know, the vaccine is that it induces what's called a polyclonal response, right? So, you know, you might have 1,000 different types of antibodies made. They're binding to different parts of the virus, right? So if one part mutates, okay, that one antibody is no longer effective. You've got hundreds or thousands of different ones that your body made. And so the monoclonals have been great, but probably some of them less effective against the new variant. Because again, you're only injecting, say, 2 or 3, and they're binding to just one specific part, and that part may be mutated. So that's kind of like my take on monoclonals at the moment. Did you want to add anything, Josh?
No, I don't think so. We you know, kind of on a more personal level here at the college, we've had a handful of our Albright community that I'm aware of that received that treatment. It has become much more readily available for people, even through the emergency room, or as an outpatient treatment to get that done. And that passive immunity is obviously making a big difference for people overall.
Right, and that's actually a really good word to use. I'm glad you brought that up, because it is passive, meaning, you know, once those antibodies you know, degrade and go away, which they will after a few weeks, then you're left potentially vulnerable again. And so again, we come back to vaccination. I mean, I would argue there's no downside. Right, but the monoclonals, they have to be given very early during infection. They're meant to stop the virus from replicating. And the disease that comes from this, like the inflammatory aspect of the disease, that comes weeks 2 to week 3. And so the damage has already been done. If you give it too late, the damage has already been done. And that's one of the issues with these monoclonals, and frankly, some of the issues with the new drugs that were just authorized. So I guess we should just jump to those, right? So I'll just give a brief kind of primer on this. So from the virological side of things, we've got molnupiravir, which was by Merck, and we have, was it Paxlovid? Is that how you say it, or something? Yeah, something like that.
Yeah. I was glad you tackled the Merck pronunciation. Paxlovid, I think, is a lot easier to say.
Yeah, Paxlovid, that's made by Pfizer. So just a real quick overview, and then I'll jump to Josh with some of the clinical stuff. The molnupiravir from Merck, that's been shown to be somewhere in the vicinity of 30 to 50% effective at preventing hospitalization and severe disease. If you look at just the percentages of protection, it seems that the Pfizer Paxlovid is probably better. But okay, so what do they do? So they both were recently emergency use authorized. The supply seems to be really low at the moment. It's going to be probably a month or 2 before they're readily available. And my understanding is that they're going to be pretty much suggested or recommended, or only supposed to be given to people that are at high risk because of different factors. So it's not like you, yeah,
I'm
go
going to
ahead.
jump in real quick,
Yeah,
Adam. Because they did put out lists of pharmacies that have it, and there is one in the Reading area that
okay.
that apparently has some supply of Paxlovid, but I don't know. Like you said, it's going to be very limited right now, but it is out there. It is being distributed at this point.
Okay. Yeah, so the molnupiravir from Merck, so that is essentially, it increases the rate of mutagenesis, meaning the drug, so the virus has an enzyme that copies the genome, the RNA. So it copies the RNA to make more RNA. So it copies the genome, and of course, RNA is made up of bases, and some people are aware of, the bases of, DNA from probably high school, and you've got your A, C, T, and G. RNA is very similar. It has A, C, and G, but it has U, which is called uracil, not T. So it takes these building blocks and it copies the genome. And what that drug does, it gets into that enzyme that does that, and kind of, it doesn't stop the enzyme, but it causes the enzyme to make a lot of mistakes. So when it's copying the genome, let's say there's an A, comes across an A, and opposite that, when it's making the copy, there should be a U go opposite that, but it puts the wrong base pair in. So it makes mistakes, and those are called mutations. And if there's too many mutations, the virus just basically becomes, it can no longer reproduce. So it's changing the sequence of proteins, and proteins are not functioning as well anymore, or they can't work at all. The virus can't replicate. And so it's basically gumming up the works, and it's creating all these mutations, and just too many for the virus to handle. The virus can't replicate as well anymore, or at all. There are some risks. So it does not appear to be the more effective of the two pills. I think it's nice to have it as an option for physicians. I mean, that's just my kind of take on it. Let the physician decide if they think it might be effective. But like the monoclonals, it has to be given within the first roughly 5 days, because again, this is targeting the virus. And so if you're not stopping the virus replication, it's not going to have as much of an effect if you give it at like day 10, day 15. It's the damage has been done. The virus is already on its way out at that point. And so there are some concerns. I don't know if you've seen this, Josh. There are some concerns about possible mutagenic effect of our own cells. So for example, I believe I was reading, it's not recommended for pregnant women or women who think they will become pregnant. If I were to put something in my body, I would not put this, personally, I would not put this in my body. I would rather get a vaccine than take molnupiravir. I mean, this is a mutagenic agent. It seems to be specific for the virus, but again, we have options, luckily. I would opt not to take that particular drug. That's just my own take on it. If it was the only thing available, literally the only thing available, and I had pneumonia and at risk for, other things because I had diabetes or was, overweight and etc., I would take it, of course. But there are other options. So that's the basics of molnupiravir. Have you heard anything kind of on the clinical side to kind of add to that?
No, that was a great overview, Adam. Thanks. And I wish we could cut back to one of our earlier conversations when you were talking about the proofreading mechanism that this virus has. I remember that very well when we first started doing these discussions. But there are definitely concerns with this medication, and so in people, especially women of childbearing age, like you said, there has to be a discussion between the physician and the patient regarding the risk benefit, and so there's certainly some medications have that, where you have to really weigh the risk benefits, and that those discussions can be difficult. And so this is certainly falls into that class of medications where you'd have to have that discussion with the patient, and the patient should really be aware of of the concerns that the physician has, and then you work through those together.
And
I
then,
don't think this medication is going to get much traction, Adam. You know, like you said, if there was nothing else, you know, it would be something to really go after. And certainly there are going to be people, there are going to be people that need it, and places where it's going to be useful. And so, you know, those are the people where we're going to get, frankly, we're going to get more information from those people, because we'll get more real world data as far as safety.
right.
And hopefully it works well for people that end up getting it. And hopefully we learn that it's a good potential option now, and maybe even in the future against other pathogens.
Yeah, one of the issues with something that's a mutagenic effect is that unfortunately you don't often see the effects until way down the road. And so that's one of the issues. Again, there are other options. I would opt not to take molnupiravir. The other option is a Paxlovid from Pfizer that has a higher percentage of effectiveness of hospitalizations and deaths. And that targets a different enzyme of the virus, a completely different process of the virus. It's not a mutagenic effect. It targets an enzyme called protease. And so we actually have in the scientific and the medical realm, we have some prior sort of exposure, if you will, to protease inhibitors, specifically for HIV. There's some very good protease inhibitors for HIV. This is a different enzyme. It works a little bit differently, but it's the same kind of general idea. This is a viral protein, and it's an enzyme, and it's called a protease. And what proteases do is they basically cut proteins. And so SARS-CoV-2 makes a big, long, what's called a polyprotein, and it has to be, you can almost think about it like a pearl necklace, I guess, right? Like each pearl would represent like one enzyme, one protein the virus needs. But when it is first made, it's made as this basically beads on a string. And if it stays as the beads on the string, it's not going to be functional. It can't do anything. It needs to be clipped to reveal the different individual enzymes and proteins. And that's what the protease does. And so if you inhibit the protease, then you inhibit the replication cycle and the virus is dead. That's what Paxlovid is doing. And at least early on, it seems to be effective. It's inhibiting this viral protease. It also interestingly has to be given with ritonavir, which is, again, we have precedent, my understanding with that. And you could probably explain that better. It's actually two drugs in one. You have to give ritonavir along with this Paxlovid for it to be effective. Do you happen to know why that is, Josh?
Adam, I don't know about that.
I think it has something to do with, no, and I don't know the details here. I think it has something to do with the drug, the Paxlovid, I think would be cleared in the liver, I believe, by enzymes in the liver that basically try to rid our body of chemicals. And so this would be viewed as something, I think, that's like bad. And so it would be like clipped or cleaved or degraded by the liver. And I think ritonavir helps prevent that degradation so that the drug itself stays in its functional form. That's my understanding, but you have to give this ritonavir along with the Paxlovid. I was reading about that. Yeah, but
that
again,
is similar, Adam, with the HIV treatments that it's a cocktail
right.
for these antivirals to work well.
And again, they have to be given very early, like from symptom onset, from the day of symptom onset, or that first PCR test or that first antigen test that comes back positive. Within those first no more than 5 days, this drug has to be given, or else the effectiveness is going to drastically go down, because again, this is a viral inhibitor.
And that's the same way our influenza treatment is.
Right.
The treatments, if not for influenza, if the treatment's not given within 48 hours, you're unlikely to see benefit unless you have severe disease.
Right. Yeah. So that's an overview of some of the pills that just came out. I just want to mention, you mentioned about the cocktail thing. I mean, HIV mutates very, very quickly, more so than many other viruses that are known. And so, yeah, the cocktail, I mean, you have to give 3 different classes of drugs at the same time, or else the patient's going to develop resistance. And actually, I worry about resistance with SARS-CoV-2. So yes, SARS-CoV-2 does not mutate as readily as HIV, that's for sure, but it can still mutate, as we know, right? And if you put a selective pressure, such as this Paxlovid on it, you're giving one drug to target one enzyme. And in my virology mind, I can imagine it, again, when you go into the real world, when you're giving it to millions of people, I can imagine very quickly that there will be a variant of SARS-CoV-2 arise that that Paxlovid will not be effective against, because you're only targeting one enzyme with one drug. And so it might be effective in the short term. I hope I'm wrong, but there are plenty of examples out there from other viruses where if you hit it with the selective pressure targeting one thing, it can mutate potentially to get around it. I'd feel much more comfortable if there was a second drug, kind of like we do actually for Hep C. I mean, Hep C people can be cured now of Hep C, but they're given a 2-drug cocktail. So you're hitting the virus from 2 separate proteins at once, and so it's just mathematically less likely that you'll develop resistance. And so that's my chief concern as a virologist is developing resistance to the Paxlovid. But yeah, in the short term, hopefully it'll remain effective. Yeah, so I think we kind of touched on most things that we wanted to kind of go through and kind of the state of the pandemic at the moment, at least from the the virological and the clinical standpoint. As we've been talking, is there anything else, Josh, that you kind of thought about or wanted to mention?
I think you're right, Adam. I think we covered what we wanted to today. We could go on and on.
Yes, we certainly could.
But no, I think we covered a lot of good topics today, and unfortunately, well, not unfortunately, there's gonna be information about COVID for decades to come, and we're learning so much. If it weren't for the fact that that people are getting so sick and dying, it's otherwise there's so much opportunity to learn about immunology and virology. It's and from a clinical side, we're learning a lot that way too. Unfortunately, there's just so much suffering that's coming along with our knowledge gain. So hopefully, like all things, we'll come out of this stronger, and we will come out of this. I remember thinking that it would just be 18 months, and here we are at 2 years, and we have a long way to go. Certainly the light at the end of the tunnel. Some people think Omicron's the answer. It's spreading so quickly. People are getting sicker faster.
Right.
So there's less chance that people are going to be spreading it unknowingly.
That is a good
Just
point. Yeah.
It's a question of whether or not we can get through this wave without a new mutation coming in that's going to evade immunity even better than this one is.
That's a good point. I'm really glad you brought that up. Yeah, the reason that SARS-CoV-1, so like the classic SARS from 2003, the reason that didn't take off is because pretty much the only people that were contagious were pretty much people that were symptomatic. So it's very easy to isolate somebody that started showing symptoms and then stop the spread. And as you mentioned, I'm glad you brought it up. Yeah, I mean, the incubation period from the moment of exposure to the moment that you develop symptoms for the original SARS-CoV-2, the ancestral one from, I guess, late 2019 or so, that had a 6 or 7 day incubation period, and people could start being contagious before symptom onset. And that's I think why it spread so readily as it did worldwide. And Delta, the incubation period is on average about 4 days, and I believe for Omicron it's thought to be about 3. Is that correct?
Yep, 2 to 3 days. And then you look at how long it took for those first 1 million cases to go, and then you look at Delta. Delta was supposed to hit United States in March. It didn't come till the summertime, and it took a long time to become dominant. And Omicron that's not Omicron at all. Omicron is showed up and is just like wildfire. So it's hard to imagine one will be worse than this, Adam. It's scary. It could happen for sure. We could have a major shift in the disease in a bad way. So, we'll continue to hope that we don't see anything like that. Um, but maybe we'll get out of this in the next 6 weeks, which a lot of experts are saying.
Well, we need more people vaccinated. Fortunately, we have other options at the moment. We have these pills which might help save some lives. We've got masking, of course, and those things. But they're early on. What's that?
It would be nice if people didn't travel all over the world constantly.
Right.
If we could just slow that down a little bit on top of everything else. But I don't know that we'll be able to. I don't know that we have the collective fortitude to do that again.
I remember early on during the pandemic, people were hoping for maybe COVID zero. That's what a lot of people call, meaning COVID goes away, right? It's literally gone. That I think that ship has sailed. I think we use antigen testing. Hopefully, supply will increase with that. But we use testing, we use masking, we use the vaccines, we use other strategies to try to get back to as normal life as we can. And I think that you can have a get together. You can have a this or that, and do it sound like following sound scientific principles as well. Like, I don't think we need to be as isolated as we were from other people. We need that social interaction. And so for example, like at a holiday party I went to, everyone had to have a negative rapid antigen test before arriving. And is it no risk? No, absolutely not. It's not no risk, but everyone present was vaccinated. Everyone present did a rapid antigen prior to arrival. And so, in our case, we all felt comfortable that was the lowest risk way to still see each other for Christmas. And, I think that's okay. We need to try to get back to some semblance of a normal life pre-COVID, but do it following, guidelines as much as possible. But there's a way. There are luckily tools in the toolbox now versus when we first started doing these conversations. It looked a little more bleak.
Definitely.
Yeah. All right. Well, it was a pleasure as always. And once Omicron goes down and things dial down a little bit for you, if that ever happens, I hopefully go to lunch or something. All right. Well, again,
That sounds great.
Yeah, thanks for joining me, Josh. And if anyone has any questions from the community, I mean, that's kind of why we're here and why we kind of do this, is to help educate the Albright community and answer questions. And so if you have any questions, please let us know. We're happy to answer them. So, all right, take care. Thank you.
Thank you. You too.